This is Lung Cancer Voices of Hope. I'm Ann Steagall, a thoracic oncology nurse, and I lead the patient services and healthcare delivery team at LUNGevity Foundation.
And I'm Dr. Misty Shields, a thoracic medical oncologist and physician scientist at Indiana University School of Medicine. Today on the show, we'll be discussing what happens when you're diagnosed with lung cancer. We have two guests today, Dr. Ann Chiang of Yale University and lung cancer survivor Lisa Bistline. Welcome.
Thank you.
Hello. Thank you so much, Ann and Dr. Shields, for having me on the show today.
Lisa is a 6-year survivor of non-small cell lung cancer. And Lisa, could you tell us a little bit about your story?
Yes, thank you. I was diagnosed with stage 4 lung cancer, December 26th of 2019. That is a day that sticks in my memory. I'm usually terrible with dates, but that is a date that I will never forget, nor will any of my family forget. That morning, I had to go in for a PET scan. And so I went for the PET scan. And after that, my husband and I went and had breakfast as we waited, because I was to go see my pulmonologist that afternoon for the results. While eating breakfast, I broke a tooth on an egg. And I'm like, oh my gosh, this is not a good sign. If I'm breaking a tooth on an egg. That afternoon, we went to the pulmonologist office and had a little bit of a waiting for him. And, your nerves are just all over the place while you're waiting, and went into his office, and he came in with the scans and pulled them up on the computer, and he said, you have lung cancer, and it is stage 4. And I just gaped and said, I have lung cancer? And I looked over at my husband and I said, I have lung cancer? And I'm like, are you sure that what's showing on the scans can't be something else? And he's like, no, it's cancer. And, it's already stage 4. And I said, I can't believe I have lung cancer. And I sat there for a little bit, and I finally just looked over at him and said, okay, what do I do? What's the next steps? How do I battle this? And my journey began.
Lisa, take us back. You've told us a little bit about you went out to eat breakfast. What brought you to the PET scan to begin with? What symptoms did you have? And you say you were completely shocked. What were your thoughts? What did you think you were going to learn that day?
I thought I was going to learn that a mistake had been made on my CT scan. So my story kind of is like a lot of people. I had no idea. My youngest son had been sick, and I had had him at the doctor's office for this cough. He'd been on antibiotics a week, didn't get better, took him back. I was starting to really cough, thought I had the same thing as him. The doctor's office did perform a chest x-ray because my son had gotten worse instead of better, and performed a chest x-ray on both of us. And the doctor said, actually, his chest x-ray was not that bad, but he called me on the way home and he said, your chest x-ray shows a nodule. And I said, no big deal. I live in the Midwest. Lung nodules are extremely common, especially for those of us that live out in the country and do, my parents farmed, and I was active with them on the farm. I said, oh, no big deal. He says, oh, I'm so glad. He says, a lot of people get very nervous about that. So glad you're not, When your infection clears, let's get you in for a repeat chest x-ray. Well, time goes on, and sometimes you procrastinate a little bit, but I got the repeat chest x-ray. He said, it's still there. He said, the next path is to do a CT scan. I said, sure. Okay. No big deal. I actually had a work trip to New York, so I postponed the CT scan until even after that. So this all started like in September, and it was finally the first part of December when they called I got the appointment, finally middle of December for the CT scan. I went and had the CT scan in the morning, and the doctor's office called within just a couple hours of that CT scan and said, the doctor'd like to meet with you. Well, I knew instantly, that's not right. And I said, how soon? And they said, as soon as you can. I said, well, I can be there like in 5 minutes, because I was really close. They said, come on in. And I'm like, ooh. And the doctor came in and he said, I don't know. I don't know how we missed this, I don't know how this is there. He said, this is more than a nodule. This has got to be cancer. And he said, we're going to get you into pulmonologist, oncologist, radiologist. I know it's December. I know it's the holidays, but he'd already said, we're going to get you into all of these things. So I was holding out that hope that when I had the PET scan, he was wrong. That he was wrong and it was infection. It was, I don't know, a misread, something. But I was hoping he was wrong. He wasn't.
And how long did it take from the time that you had your PET scan until you started your first therapy? Because that was chemotherapy and immunotherapy. And by this time, was this early 2020 when this started?
Yes. I got into the oncologist in January, and we had biopsies done in January. And I started my first treatments the 1st of February with chemotherapy and immunotherapy. We did do the biopsies and sent them off for biomarker testing right from the start. It showed that there were no biomarkers. And when I say no biomarkers, I mean there was nothing that matched any targeted treatments at that time, other than following the path of just doing chemotherapy and immunotherapy. So I did that, and I would have some months, I would have a PET scan every 3 months, and sometimes I would have improvement. Other times I would have progression, and we would have to continue to switch medications. My lung cancer had started out in the left lung, the pleural lining, and the lymph nodes. It then, even with treatments, spread to my liver, a place in my spine, and 2 places in my pelvis. We did a liquid biopsy, still nothing matching for targeted. Stayed on the course of chemo, immunotherapy, and even did some radiation to the bone spots. And I went through 8 different medications. There was only 1 chemotherapy left to try, and we didn't hold much hope in that. And my doctor said, would you do biopsies one more time? One more time. I said, I got nothing to lose at this point. I got nothing to lose. And it was like you could just feel the cancer gaining control over your body. And so I underwent the biopsy. Unfortunately, there was an error in the grabbing of the tissues and where it was sent. So I had to undergo the biopsy again to get the tissues and shipped out. This time, my doctor called me and said, have you seen the report? Have you seen the report? Because she knows I am a very much watching for results and on the portal person. And she said, did you see it? Did you see it? And I said, I did see it. She said, you're ALK. You're ALK. There's treatments. And she says, I know I've got an appointment with you tomorrow morning, but I was too excited. She said, I had to call you. She said, I'll see you in the morning and we'll discuss what we're going to do. And it was like, it's such a surreal thing. Only somebody with progressing stage 4 lung cancer with only one more treatment to try, can understand how exciting it was to learn that something had changed in my cancer. And all of a sudden now I have the ALK gene. And there's targeted therapies for that gene. At that point, we didn't know whether they would work or not, but it was more than I had going for me. I was so excited. And so the next day I went, we decided on the targeted therapy pill. I started that drug. At my 3-month PET scan from that, the spots in my pelvis, liver, and spine were gone. Everything in my lung had shrunk, but there were still active cells there. Another 3 months goes by, and everything in my lung is gone. Nothing is showing up. There is no active disease showing. I went from stage 4 progression, not much left to try, to living now my every day and still having my PET scans, still taking treatment. But this treatment is working for me.
That is such a fantastic story. So it seems that first year or so, Lisa, was really pretty rough. And I'm wondering, what did you find was your best support? And how did you kind of move forward through all of those biopsies and liquid biopsies that kept saying that you did not have a biomarker? What did you find helpful in the support arena during those times?
I was desperate for people to share with, and desperate for, somebody to give me information. And I went to where a lot of people go, to the web. And I found great support groups. I found LUNGevity, and they started up. And also, you got to remember, this is time for COVID. So everything went to the computer and Zoom meetings, which was fantastic for me because then I was able to participate with the support groups and being able to hear people across the country that was experiencing what I was experiencing, and to hear all of their knowledge and find different resources that you could do, and knowing some different questions to be able to go in and ask my doctor about was such a help. Just such a huge help. My husband was right there beside me. My kids were right there beside me, and their support and helped keep me going, and also, looking forward to spending time with those. I've got grandkids, so looking forward to spending all of those moments with them kept me going. But the support groups really, really helped a lot.
Thank you so much for sharing this story. And I think it probably resonates with a lot of our listeners. But if there was one thing that you wish you had known back then that you could share with someone who's just starting out on this journey, what would that be, Lisa?
I would have liked for somebody to tell me that statistics don't mean anything, and that even when you're on that last drug, or you think, oh, there's not much treatment for me, wait a day, because tomorrow there's going to be another new treatment out there. And I am a big advocate for the also the knowledge of biomarker testing. I was lucky. I had a fantastic physician that led me down the pathway of getting those. I knew nothing about them when I got into this journey. I wish somebody maybe, would have explained it a little bit better to me at the start, but my doctor just did, which was in that moment was okay, because I needed just things to be done. I needed that, but knowing more about biomarker testing and more about all of the research and how fast it is changing and growing would also be very helpful, because it gives hope, and it also lets you know that those statistics that are out there can't keep up with what's really happening today.
Thank you so much. We really appreciate you sharing all of this with us. And it's such a fantastic story. And it really is a true voice of hope that you have shared today, because you're right. You've gone from probably having the worst news that you could, being persistent, continuing to have a great relationship with your healthcare team, and look where you are today,
Mm-hmm.
6 years later from starting therapy. So that's fantastic.
Yes.
Thanks, Ann, and thank you, Lisa, for sharing your journey, and what a testament to the role of biomarker testing and being persistent and having a lovely team to support you. Speaking of lovely providers, I have, again, the pleasure of introducing Dr. Ann Chiang, who is a thoracic oncologist at Yale University, a leader in the field who has specialized in lung cancer research as a physician scientist, as a clinical trialist, and a wonderful person to know, and a colleague and friend. Dr. Chiang, thank you for being here.
Thanks. Back at you, Dr. Shields. You're terrific, and thank you, Lisa, for sharing your story. And hopefully, it will touch people and really give them hope, because I think what you describe of going through each step of the process and just being honest about how you were feeling, and will help people feel better about what they're going through, and certainly have more hope and do more biomarker testing. So that's terrific.
Absolutely. And so, Dr. Chiang, as a physician who's seeing patients and treating patients who are impacted by lung cancer, when you meet a person in the clinic, a patient and their families, what do you focus on that first visit? For a listener who might be listening for the first time, they're newly diagnosed, when you're meeting a patient in clinic, what does that look like?
Got it. The first time I meet a patient, I'm going to make sure I have a lot of time to sit down. I think it's pretty straightforward. I think of it as what, where, how, when, and who. So the what is trying to figure out what kind of cancer you have, whether it's non-small cell or small cell. That usually involves a biopsy. The biopsy is through tissue, but nowadays we also do a blood test usually to do a liquid biopsy at the same time. And we're looking for example, the histology. That means, is it adenocarcinoma or squamous? That's for non-small cell. And I just tell folks, it's like, is it chocolate, vanilla, or pistachio? It's describing the cancer that you have. And then we're looking at different markers, whether it's biomarkers at the genetic level, or if it's, looking at proteins on the surface of the cancer cell. We want to know the tumor profile, is what we call that. And that will help us to understand what treatments are available. So that's pretty much the what. The where is it in your body? What's the map? And that's what we call staging. And we usually do a CAT scan or a PET scan. That's similar to a CAT scan, but you have an injection of radiolabeled sugar, so that things in your body that are actively using sugar, and that would be cancer, for example, will show up. And then we also usually do an MRI to check your brain to see if there's any cancer up there. You may not have any symptoms, you may not have any cancer up there, but that's sort of our thorough map of when you start, where is the cancer? That's the where. And then I think of how as saying, how are you feeling as a patient? Are you having symptoms? Are you short of breath? Are you dizzy? Are you having pain anywhere? That's going to be really key in determining our treatment plan, because how you feel is going to affect your everyday life. So if you're having pain, we're going to have to address that to make sure you have quality of life. The when is really the roadmap or your timeline of your disease. And, I always try to sort of say, okay, this is in the next couple of weeks. We're going to try to get all this information. We'll come back together in 2 weeks and go over the results, and then we'll start you on the treatment, and then I'll give you a timeline of what the treatment is and when we do scans and what our expectation is. The who is probably the most important, and that's twofold. One is who the patient is as a person. So meeting that person, I need to know what's important to you, how you get your information, what your support system is, what your value system is. Do you value time? Do you value independence? Are you taking care of other people? And that's really important to factor in as well. So the who is really important, and then the who is also partially refers to the team that's going to be taking care of you. And that's what we call multidisciplinary. And that means it's not just me, it's my nurse, it's my physician assistant, my nurse practitioner, it's going to be the pharmacist, it's going to be the nutritionist, the social worker, the pulmonologist, radiation oncologist and surgeon, etc., even our pathologist and radiologist. So we've got a whole village that's involved in taking care of you. And we have regular meetings to talk about patients. And we sometimes have also multidisciplinary clinics where we have the patient come in and we have several different doctors or several different disciplines coming to focus on you. So you want to have a whole village taking care of you, and we want to understand you as a person, what's important to you at the beginning of this journey.
Thank you for sharing that, Dr. Chiang, and what a beautiful breakdown of all of the aspects that really matter and in the careful selection of treatment plans for patients who might be impacted by lung cancer. And, I think Lisa's story really highlights this, the role of biomarker testing, the importance of it, and how it can define a patient's care plan. So in Lisa's case, she was fortunate to have an ALK fusion. Can you, Dr. Chiang, tell us about biomarkers? What are they? Which ones are we looking for, and why do they matter?
Absolutely. So there are two types of lung cancer. There's non-small cell and small cell. So I'm going to focus in on the non-small cell because that's where the role of biomarkers is really the furthest along. And so when we talk about that, remember the what kind of cancer you have. We're thinking about characterizing the specific cancer that you have, not only the histology, but the biomarker. And so a biomarker is just a characteristic of your particular tumor. And if we're looking at your tumor DNA, right now, there are 11 different DNA mutations or markers where we actually have oral drugs that we can take that target the cells, the tumor cells that have that particular mutation. We think that that mutation, and it's EGFR or ALK, ROS, any one of those 11, that mutation was involved in how your tumor evolved and developed. And so if we can target that particular gene with a medication, we found that people can respond very well. And so what does that mean in real life? It means that if you have, for example, metastatic disease, that instead of taking chemotherapy and immunotherapy, you could just take a pill to treat your disease. Nowadays, sometimes we do combinations of 2 pills together or a pill and chemotherapy. But the whole idea is that we're really tailoring your treatment to the kind of cancer that you have. And I think that's where you hear this term targeted therapy. If you have an EGFR mutation, you can take a medication that targets EGFR, that gene.
Thank you, Dr. Chiang. And I think this really highlights some of the dramatic advancements we've seen in lung cancer over the last 20 years, right? EGFR kind of paving the way. And then we saw ALK fusions, as mentioned, ROS, RET fusions, right? Alterations in KRAS that we're now targeting. Really, historically, these undruggable targets are now being treated and targeted, and that's really transforming patients' lives and providing the hope that we are so excited to share with you all. And so, how do you, I think you mentioned this a little bit, right, about getting a tissue biopsy and a liquid biopsy. How does a team use that information to find these biomarkers? Do you need one? Do you need the other? Do you need both? How does that testing actually go about?
So that's a great question. So when you get a biopsy, you have the tissue, the tumor tissue. And so that is already out of you, that they can send further and do this sort of testing for mutations, this tumor profiling on. That usually takes nowadays 2 to 3 weeks for the results to come back. So usually what we do is at the time that I see the patient, the tissue biopsy is already cooking, but we'll do a liquid biopsy at the same time. And what that is that for some tumors, depending on how much tumor is in your body, you may have circulating tumor cells and circulating DNA from the tumor. If you have a very low burden of disease, say just one spot, for example, one nodule, you may not have any tumor DNA that's in the periphery. So just because you have a negative liquid biopsy doesn't mean you don't have cancer. It just means that you don't have enough that we can detect it by doing a blood sample. But in any case, what we do is we take a blood sample, and that test we can also look at DNA, circulating tumor DNA, and look for the presence of some of these mutations. That test is a little bit quicker, so that can usually take a week to 10 days. And so I might get that information back more quickly from the liquid biopsy than from the tissue biopsy. We still consider the tissue biopsy the sort of the gold standard, but I think that nowadays we've done enough studies where the liquid biopsy mirrors and the results have been validated, such that if I see an EGFR mutation on your liquid biopsy, I'm going to start you on that medication based on that result. We'll still wait for that. We'll still see what the tissue says, but I'm not going to wait until that tissue biopsy result comes back before we talk about starting the pill that targets EGFR or whichever mutation that you might have. So I think the liquid biopsy is a way to get answers a little bit more quickly. If you think about it, the liquid biopsy also means that we're looking at whatever is circulating. It could be from the spot that was biopsied. It could be from a different spot. So we have the opportunity to sort of see what the whole amalgam is. The tissue biopsy is going to tell us very specifically that tumor that was biopsied and showed cancer, does it have that mutation? Nowadays, we're learning so much. We're finding that sometimes you might have even 2 lung cancers at the same time that might have 2 different mutation profiles. And so we're just, learning more and more. As you said, Lisa, the rate of progress for lung cancer is really, really amazing. And a lot of the tests, even in our improvement in biomarker testing, weren't even available 6 years ago. So the testing back then is different from the testing now.
Thank you, Dr. Chiang. And you touched upon that a lot of this focus is really led by the research and understanding and treatments for non-small cell lung cancer, usually adenocarcinoma, but sometimes squamous cell carcinoma. These are forms of non-small cell lung cancer. But you're really leading the way in the path forward for biomarker testing and implementing it in a trial setting for patients with small cell lung cancer as we speak. The PRISM study, which is a cooperative group study, S2409, is looking at biomarker testing and can we use it to define treatment for small cell? Can you tell us about that and this effort that you're leading?
Sure, I'd be happy to. Trying to learn from non-small cell where the treatments have been able to be tailored to the kind of non-small cell lung cancer that a particular patient has. I think that we're trying to apply that precision medicine approach to small cell as well. And I think now the advances in biology, and you're a small cell leading researcher, you've done a lot of this work too, we're starting to learn that not all small cell is the same, not just one size fits all treatment. But as we learn more about the biology, we can see that there are some different subtypes, and that the different subtypes, you might be able to treat one subtype and have a better response to a certain drug versus another. And I think if you go back to the immunotherapy, which right now is sort of revolutionizing the field of small cell, dating back about 6 years, the original trial that showed that patients that were treated with chemo plus immunotherapy showed that if you subtype them, and if you had an I subtype, let's call it I, that has some activation of inflammatory genes and so forth, those patients with subtype I did the best with immunotherapy. And that benefit went away in the placebo arm, so if they didn't get immunotherapy. So the idea there was that, okay, well, if we have a way to separate out these different subtypes, and if we have drugs that can potentially target the different subtypes, wouldn't that be great to create a trial to test that? And so that's what the S2409 PRISM trial is. It's 800 patients, over 800 patients with small cell. We're going to, during your initial chemo plus immunotherapy induction, get your tissue and figure out what subtype you have. And then based on that biomarker, then you will be able to get either your regular immunotherapy or the immunotherapy as maintenance, plus a treatment that's really designed to be useful in that biomarker population. So it's really a new approach for small cell, and we're going to get a lot of information just by even getting tissue from everybody and blood. And because it's going throughout the cooperative groups, it'll be available throughout communities in the U.S. and allow more small cell patients to get really novel therapeutic drugs that are very exciting.
Thank you, Ann, for all of your efforts to really make this trial happen and pioneering precision medicine for small cell lung cancer for our patients to improve outcomes. I think we're really excited to see the results of this study as it is maturing and accruing. Dr. Chiang, if you could have a word of advice for a new patient who's listening to this podcast, who may be newly diagnosed with lung cancer, what would you tell them to help them be more prepared on their visit with their new oncologist they're meeting?
I have several things that I think are really important, so I'm not going to limit it to one. The first thing I tell my patients is that it's my job and my team's job to really think about your cancer and take care of you. So if you are an anxious patient and you're sitting at home thinking about what's going to happen, how's this going to affect me, and so forth, I really encourage you to trust your doctor and your team. That's their job to worry about that. It's their job also to explain it to you. But when you're thinking about that, just say to yourself, I'm going to let my doctor do her job or his job, and I'm going to worry about what I'm having for dinner tonight or the family members that I'm taking care of. So I think that really is the place of and the role of the physician and their team to take care of you. So that's number one. Number two is that I think it's important for you to ask your care team about clinical trials. Clinical trials have really advanced nowadays. We're really testing drugs earlier in the course of disease. So previously, you might have thought, okay, I'm going to be offered a clinical trial if none of the standard treatments work for me anymore. But I'm here to tell you that that's not the case. We're actually trying to improve treatments up front. So when you're diagnosed or very early in your journey with cancer, so that we can really improve outcomes. Clinical trials, there's lots of different ones. You want to ask your doctor, is this something where everybody's getting the drug? Is this something that where I'm going to have to be randomized to one group which has the standard of care plus the standard of care plus something else? But in general, I would encourage you to think about that because I think it's the best level of care. You have a whole nother research team that's tracking you and thinking about you. And usually you have a scan that you're going to do in a very short term, like maybe 6 weeks, to see whether this treatment is helping you or not. And if not, stop it. If so, keep on going. But I think just in general, if you think about immunotherapy and the discussions that we were having with our patients when I started at Yale, for example, we put patients on clinical trial with immune therapy. And at that time, the gold standard was chemo. And so it really was through those trials that we were able to see that actually immunotherapy, I have had patients who've had stable disease or no active disease for 7, 8, 9, 10 years who only got immunotherapy, never got chemo. And that was only because they started on those clinical trials. So I would encourage you to really talk to your doctor about the clinical trials that are available there or in the region, and not be afraid. It may not fit you, or it may not be the choice that you decide at that point, but I would definitely not be afraid to ask about it and find out more about it.
Thank you, Dr. Chiang. And I can't echo that enough, that trials are tomorrow's advancements being studied today, right? And this is how we get, to moving these new therapies, through safety pipelines, through regulatory avenues to get them safely to patients by studying them in these settings. And trials are so important to making these advancements happen. So thank you.
Thank you so much, Dr. Chiang. Thank you so much, Lisa. This has been a great episode of our podcast. I just want each of you to give us one last statement. Lisa, if you could say one thing that throughout this entire 3 years that you've been undergoing therapy and the changes that you've gone through, what's the one thing that you feel has really empowered you to be your own advocate and to be as strong as you are today?
That's really a tough question. It's a good question, but it's a tough question because I've been on the journey now for 6 years. And at different junctures, there's a lot of different things. The one consistent thing has always been my support groups. And I would say external support groups, because your family is going through the journey, but it's different for them than it is for you. And truly only another lung cancer patient, survivor can relate to those feelings that you're having, to the treatments, to the side effects, and all of the emotions and the hills and the valleys, and can also give you their experiences and share their knowledge with you. So I encourage everybody to participate in support groups. They are just so helpful, and they do empower you to be able to know what questions to ask a physician. They empower you to understand that, oh, that is a side effect of my medication. Or, some of the medications like the targeted therapies do mess with our minds a little bit. And so it's great when you hear somebody else say something about that and you're like, oh, thank goodness. Okay, it is the medication. Because one of the fears that you live with daily is that I know my cancer's coming back at some time. I haven't been cured because there is no cure yet. I'm hopeful that there will be yet during my journey here. But, you're always thinking that pain, that ache, or, oh my gosh, I'm confused and can't remember things. You're always thinking, is that the cancer reoccurring? And so it's nice sometimes for those that are going through the journey to remind you that your medications have huge effects and impacts on your daily life also. But I'm one that I said, I'll deal with any side effect that there is to take a drug that's working. And so it's a wonderful thing. And to both of you physicians, Thank you for the research. I cannot thank researchers enough. And I ask that everybody advocate for the funding for research projects that everyone has going on, because that is the future. And like I say, I'm hopeful you'll come up with a cure. And I will live to be 100 like I've always wanted to be.
And Dr. Chiang, in your career, we've seen so much, and Lisa mentioned it as well, how fast our science has been moving. But what is the one major thing that has really given you hope for our patients who are impacted with lung cancer?
I do think that the pace of progress is really amazing. And I gave a talk today where I showed the advances in small cell in the past 6 years, and we've had 5 really major positive practice-changing trials. And I compared that to the 6 decades beforehand, where we also probably had 6 major advances that helped patients in chemo and radiation. So 6 decades, 6 years, it is really moving fast. And so I think that, as Dr. Shields said, the research that is going on now is something that in real time is translating into advancements in outcomes for our patients. So I just want to really emphasize that message of hope, and that's really due to, I think, the communication, the passion, the community of cancer researchers, clinicians, but also patients like you, Lisa, that are advocating for research, and also organizations like yours, Ann, LUNGevity, and others that are also supporting our patients in their journey. So it's an exciting time. It's time for a lot of hope, and I encourage people to continue to stay tuned.
Thank you, Dr. Chiang. Thank you, Lisa. And thank you to all our listeners today for tuning in to this episode of Lung Cancer Voices of Hope, where we discussed what happens when you are newly diagnosed with lung cancer. I want to share that you can find lots of resources at LUNGevity.org. As Dr. Chiang mentioned, there are also other lung cancer foundations that you can go to for resources. We at LUNGevity have several online support groups, as Lisa said, that can be very helpful to you if you join a community. We have lots of educational materials on our website, videos, and if you are a patient who has been diagnosed with small cell, please join our community of small cell smashers. We have a Facebook page there, and we also have live chats once a month that you can join. So thank you again for listening to this episode.
If you found the information on this show today helpful, please be sure to follow us in your favorite podcast app and leave a review so others know to listen. Thanks again for listening.